Welcome to Swallow the Gap, the podcast that delves into the critical world of dysphagia practice and education. I'm your host, Dr. Tim Stockdale, and I'm thrilled to have you join us for conversations aiming to bridge gaps in understanding, knowledge, and implementation surrounding dysphagia intervention. We will be a force for change by inspiring critical thinking, facilitating discussion, and promoting professional development. Swallow the Gap is here to discuss, inform, inspire, and connect you with a vibrant community who is dedicated to making positive change. Together, we'll unpack challenges and be open about our own struggles and work to bridge gaps in our field that impact the lives of those living with swallowing difficulties. Our opinions should not be taken to represent our employers or the groups with whom we associate. Nothing we say is legal advice, and nothing should be taken without scrutiny. While we strive for accuracy, we do not imply perfection. We value diversity in backgrounds and opinions, so our guests will not always reflect what we believe. In fact, we may change our minds on topics as we learn because this is how progress is made. Through discussion, critical thinking, and open minds, we serve as catalysts for advancement in medically focused speech-language pathology. Before we get started, I'm thrilled to announce our first sponsored episode. This episode of Swallow the Gap is sponsored by Bracco Diagnostics. Bracco is the maker of Veribar barium sulfate, the only contrast validated for standardized, well-tested protocols during modified barium swallow studies. For more information, visit veribarmbs.com. Today, I have two individuals with me, the first of whom you are familiar with, Jo Puntil, who's been a speech pathologist working in the ICU for over 30 years. She's an ASHA Fellow. She might try to downplay how cool she is, but she has contributed a tremendous amount to the field. And we also have Sam Walker, who is a speech pathologist, a business owner, and a family member of somebody who has undergone ICU care, pretty significant ICU care. Sam is the owner of Speaking of Samantics and also SLP Test Prep. Do you mind, just before we go into your story a little bit, just tell maybe a tiny bit about what SLP Test Prep does, then we can circle back?
Yeah, really quickly, I'll sort of just go a little step behind before that. I just plan to be a regular SLP sort of my whole entire life. And during my clinical fellowship, right in the smack dab in the middle of it, COVID hit. And my supervisor was pretty strict. And because ASHA didn't make like a specific statement saying that clinical fellows could work teletherapy, she didn't want me to work for like 2 months.
Oh, wow.
So I was straight out of graduate school, ready for student loans to start up. And I was just panicking. So I turned to my creative side, and that's how Speaking of Samantics started, which is just a design merchandise type company, sort of a creative outlet for me. Which then also turned into a lot of graduate school advocacy work. And I always knew I wanted to create something to help students who learn visually like I do. Initially, it was just going to be a fun little thing I did with Kahoot games, sort of making praxis studying more trivia and game-based. And now we've had or helped 1,500 speech pathology graduate students pass the praxis. We've also taken one school out of probation due to praxis scores, and we go live every Tuesday to do a new Kahoot game.
That's cool. I love the advocacy part. And so that's one of the reasons why I wanted to have you on the show. There are a couple of angles to it. First of all, you're a speech pathologist. Second of all, you have a family member who has been tremendously impacted, and thus you have also been impacted. But you've seen gaps in our education, and you're doing something about it. And that is in particular what I love about what you're doing. You got a school off of probation. That's something else. Sam, what was it that inspired you? I know you mentioned you had free time and you wanted to have a creative outlet, but for SLP Test Prep, there must have been some things during your graduate studies that influenced you to say, this is the way that I'm going to address this. This is the way I'm going to address these gaps. So what gaps did you see in your training that you thought necessitated the business that you've created?
So I did go to New York Medical College, and I will say I loved that program. It was a more medically based program, and due to what my mom went through, I went to a more medically based graduate program thinking that I love trachs and vents, and that's what I wanted to go into because I had the experience both with my mom, and then I wanted to learn sort of the speech pathology position on it. But I found that I learned in such different ways that the sort of just regular PowerPoint and lectures never stuck with me. So in graduate school, I would always go home and I bought this dry erase sort of wall decal that I put on my graduate school dorms
Mhm.
wall. And I would write, I would draw, I would highlight, I would color code
Yeah,
just to help internalize that information. I would make worksheets for my classmates. I would make little quizzes for my classmates because all of that just helped me learn. I wasn't someone who could just rotely memorize information. I had to make it active. So then when it came time for the praxis, all throughout graduate school, I was just trying to be that person that just memorized for the test, passed the test, and move on to the next one.
sure.
When it came time to the end of my grad school program, and I was like, I memorized all that information,
That's
but
fun.
I don't really know how to use any of it. So then I turned to the advanced review book and I was like, let's do it again. Let's just memorize this from front to back to pass the praxis. And it was miserable. I hated coming home and studying. It was just
Mhm.
horrible. I ended up passing the praxis with 1 point. I mean, a pass is a pass, but I said to myself, there had to be a different way to help graduate students sort of learn this information in a way that didn't feel pressured, it didn't feel fearful, and it also sort of allowed them to ask questions. And then sort of in my grad school advocacy, coming from having the Speaking of Semantics page, I realized that I had a 3.2 GPA going into graduate school, sort of applying to graduate school. And I started talking about that more. And I realized how many other students are in the same boat. This whole idea of like, everyone has to have a 4.0.
Mhm.
I was like, that's not true because I got in. So the more I started talking about that, the more I realized that students needed more help and kind of handholding. And I was just like, let me try to do something fun, right? Praxis setting is not fun. Studying for any test is not fun. Let me see how fun I can make it. Once you add a little friendly competition, I give away like stickers at the end of the week, forever's on the top of the leaderboard. I realized that students were able to have fun and also remember the information.
What's really neat about that is so you've identified to me a gap in learning methods, pedagogy, andragogy, the science of teaching and learning overall. And PowerPoints, I mean, they have a purpose, but doing PowerPoints 100% of the time, we tune out after like 15 or 20 minutes. Not everybody, but there are different ways to learn that really supplement that. And so I think you've done well to tap in to some of that. But the other thing that's really cool is the idea of being anxious about learning or being fearful about learning. I can relate to that in so many ways, particularly if I go back to grad school, being afraid that I would fail out or whatever. And that is not an environment to me that's conducive to being able to apply and integrate what you know. And so I love the spin that you've put on it to make it fun. I mean, if we can become interested in something, if we can love what we're learning about, I think we'll get more of it. In fact, I've used this story before. During COVID, my 6-year-old, who's 6 now, was in forest school instead of preschool because it was outside. It was a little safer with COVID. And they employed child-led learning. You're walking around in the woods, you see this stick with green stuff that's furry growing on. You're like, what is that? Oh, that's moss. And like they teach them about moss and it sticks because they care and they're interested in it and they're making connections and applying it in real life. And there's so much to be said about the science of teaching and learning. And I think that's cool how you've gamified it and tapped into that and trying to make this something that's more enjoyable because I mean, really learning can and should be something that can be fun and is interesting to us. And that applies, I think, not just to students, but it applies to any SLP who's in a clinical setting and just wants to learn more about that. So very cool.
I'm just curious, did you find when I mean, I was in grad school such a long time ago, but did you find that your teachers that were actively, not just academia, but your teachers that were treating clients, patients, whatever you want to call them, did you find that they taught differently than strict academia teachers? So that with it, did they apply things a little bit differently, and was it easier for you to learn that way?
I found it was easier to relate to professors like that, or even if they weren't treating clinically, if they were bringing examples. And I think this ties into my mom's situation and me in graduate school that learning when you have, or learning about something when you've never had experience with it is
Mhm.
so incredibly hard. Like when I go through the dysarthrias and the different speech characteristics of dysarthrias with graduate students on our Kahoot, most of them have never actually heard most of these types of dysarthria. So learning about them and then understanding them and seeing them is so different. I can tie that to like my mom's situation with the trach and vent, learning it in graduate school plus seeing her, but I can also tie it to most of what we learn in graduate school. And I think that's sort of what helps students in my SLP test prep is that I'm bringing in YouTube videos, I'm bringing in pictures, like as many things as I can find to say, here's the textbook definition, but here's really what it means. Here's what it looks like. Here's what it sounds like.
Yeah. Okay, that's super cool. So I've got to piggyback on that. The learning about something without the context of what it means and why it's meaningful is so much wasted energy goes into that. Like in some of my classes, just memorizing stuff and like, okay, this is the tongue. This is how the tongue moves. But not knowing, well, why does the tongue move? What is it contributing to? What's the bigger picture? Like you're studying each tree so closely that you miss the overall form of the forest to understand why the trees are important, why all that matters. And so this is in a presentation I gave on curriculum design for dysphagia. I always want to go through why we care about swallowing first, go broad to small before we go into all the nuances of physiology. And the analogy I'm thinking of, okay, what if I tell you we're going to build this thing and I need 4 wheels, I need a flux capacitor, I need some, I don't know, uranium, whatever it is that they used. And you're like, what are you talking? What are we doing? I have no idea what we're doing. And it doesn't mean anything unless I'm like, we're going back to the future, baby. Like we're going to build a time machine. Like it doesn't make sense unless you know the purpose and get the big picture for it. So that's super cool. Kudos for doing that.
I wonder why, and I remember for many years I volunteered at ASHA, our clinical competencies and all that. The biggest to me bridge, I'm glad what you're doing, Sam, was why don't universities communicate with clinicians more? Because we could give you every one of those. We could walk in every day and take a video of a patient, get them to sign something so that you can see what what oral apraxia looks like, or verbal apraxia, or an ataxic dysarthria, flaccid dysarthria. I can give you all of that in a week. So why don't we have that bridge between academia and hospitals and clinics? Because we all have it. We're all happy to do it. And in this day, it's so much easier than 30 years ago. You just take a phone out and take a picture of it and video of it. So that would be nice. There's another project for you in your business. There's clinicians out there that would be happy to share. Like, this is a great shot. I have a great video of someone who's a Rancho level 4. You hear about it, you hear about the agitation, the confusion, but until you see it and see a patient screaming at you and super confused, do you really connect those dots? And you never will forget what a Rancho level 4 looks like.
Right. And then taking an exam about the Rancho is so much easier because you have that visual, the auditory, and the deep understanding of what the definitions are or what the terminologies mean.
Well, there's your next business venture. I'm happy to help.
We already tried with Tim.
Let's do it.
He taught a crash course and he showed MBS videos because that's another thing. We talk a lot about swallowing and the deep intricacies of swallowing, but we're only talking about them. So it's so much easier and nicer when you can visually see an MBS, you can see someone aspirating, you can see all that, because sometimes it's hard. Sometimes we don't even know what we're looking at for a second.
Well, and it literally happens in a second too. Like 1.5 seconds. How many cranial nerves, spinal nerves, muscles, just like bam, 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 doing all this stuff in a very short period of time. There's a lot to it.
You're in there in real time watching, and also watching the patient and having the patient do as much as possible on their own, and then calculating in your head what needs to be done for a compensatory strategy. And you go back and you think, wow, okay, I missed that. And it's okay to miss things. It's in real time. That's why we review things. I mean, I had a patient, this doesn't happen often, but so our acute care therapists run down and do all of the outpatient therapists. And I live like in an island, and I live closer to Vegas than I do to Salt Lake. So we get all of these outpatients and all the nursing homes. And so we walk into radiology cold oftentimes. You get this consult for some guy who walks in with hypertension and says, I feel like I've got something stuck in my throat. And it's 9 times out of 10, 99% out of the time, it's an esophageal dysmotility. So you have this guy walk in, this just happened to me last week, and you always do that initial view, and you're looking at the initial view to look at anatomy. You haven't seen physiology, right? And I see this big, huge mass in this guy's pharynx. And I thought, no. and you have to learn how to just be deadpan. Because you're not the person to tell him. So you want to go through the whole procedure and then you review it with the patient, hoping that he doesn't say, what is that? Luckily he had some esophageal motility, but then you've got to communicate. That's the thing that I think grad students need to learn is how do you stay professional, flat, when you do see something that's really alarming, but go through the motions, and then how do you communicate that with the printed doctor? And it's like, this is provider to provider. I cannot leave a message. Well, who teaches you that, Sam? And then that guy got in, I kid you not, in 4 days for a CT and ENT consult, and he just got flown to Salt Lake for emergent surgery. And it's the speech pathologist that sees that. What you're learning in school is really good. I wish we could teach the students a little more of the nuances for communication and that pragmatic interchange. Or you hope you have mentors that say, you got to take the time to do this. You can't let this gentleman fall through the cracks. What if that's you or your mother? Like, okay, right.
And another thing too is that when students or new clinicians or just clinicians in general understand what's going on in a deeper level, like they actually understand everything that's going on, it is so much easier when then they have to explain that to either the patient or the patient's family, because then they can explain it in a way where the patient will then understand. I'll give you a prime example of that. And I guess this is a good segue for me to start talking about my mom's situation. But so my mom has a very extensive medical history. She had scoliosis. She has a Harrington rod, got put in when she was 15 years old. She had a revision surgery when I was in 8th grade. So huge medical history, but she has frequent UTIs, and she worked for a cardiologist's office. So she would always just get her urine tested. She knew she would go on antibiotics. It would just be a consistent cycle until one went unnoticed. Kidney stones formed. The kidney stones scraped her bladder, which caused her to become septic. Now, she went into the hospital with flank pain that was really intense. And then we got told she was going to stay overnight and that they were going to blast the kidney stones the next morning. They went in, they tried to blast it. They realized that she was septic. They didn't finish the surgery, and they immediately put her on propofol in a medically induced coma. Now, I was in college at the time. I knew I wanted to be a speech pathologist, didn't really know much about the medical side. I had worked in an early intervention center for kids who were deaf, so I had that experience, no real medical experience with trachs and vents. Honestly, didn't really know much about it. So they brought us in. She was extremely swollen, in a medically induced coma, and we were all just very lost. We were like, how did it go from her just having flank pain yesterday to now she's in a medically induced coma? The 3 of her kids are looking at us, looking at each other, and her husband is just like, well, what do we do?
Sam?
Yeah.
I am so sorry, but I'm getting chills as you talk about this. One of the reasons is because almost the same thing happened to my wife. She has a ureter obstruction, the tube that connects your kidney to your bladder. She has a congenital obstruction there. And so a long time ago, she had this huge, awful event in the hospital. But after we moved to Utah, not like a year after, something like that, she went in, what was it? It might have been to get kidney stones blasted. It was something within the urinary tract. And she ended up going septic. She didn't have to go on she didn't have to get trached, but she was on BiPAP for a while. And it was just a miserable, frightening, horrible experience. So I'm just like, the similarities are so interesting, so eerie.
It's scary. And UTIs are so common. And that's why whenever anyone I know says, oh, I'm having weird pain, I'm like, please go to the doctor, because you just never know. So she was intubated. A lot of this is sort of a blur, partly because I didn't really know the intricates of what were going on, and because I was just in shock most of the time. So she was intubated. It was going on over a week. I think it was 10 days of intubation, and they were at the sort of fork in the road. Do we keep her intubated or do we trach her? They ended up traching her, and she was still on a ventilator in a medically induced coma, and then she got ARDS. Now, when they said ARDS, I happened to be in the room. I also have 2 brothers, and the doctor had told us, she has acute respiratory distress syndrome, something is wrong with her lungs. Continued to explain it, and then said, whatever you do, just do me a favor and don't Google it. Now, I
Yeah,
feel like
of
that was good advice for me. Did I listen to it? No.
course not.
But I went into it knowing like, okay, if he's saying that, that means that Google is pretty aggressive with what they're going to say with what ARDS is.
Mhm.
So I went home, I Googled it, and most of what it said on there was most people don't survive, people are going to die from this, all of that dramatics. So, but that was something that the doctor like forewarned me of, and I appreciated that, although I didn't listen to them, but I appreciated that. And I feel like that goes hand in hand with understanding what these diagnoses and these diseases are in such a deep level that when you're telling it to the family, you can give them advice like that. So she ended up being in the ICU for over 4 weeks.
Wow.
She then transitioned to a ventilator weaning facility where she was there for about 3 weeks. But with that, she had loads of anxiety now. She was hooked up to a machine to help her breathe. Couldn't walk anymore because her muscles had atrophied so much from being in bed for so long, and sort of just a wreck. Now, my mom is an absolute warrior. She had a smile on her face every time or every day. And there wasn't a single day for the whole 72 days of this experience where she slept in the hospital by herself. It was either my father or my siblings or me sleeping right next to her in the hospital because she had built up so much anxiety. Now, a little rewind, my mom, when she got her revision surgery, she was on painkillers. They didn't sort of tell her how fast she can get addicted to them. So she became addicted to them and had to sort of cold turkey get off of them. And now she has a huge fear of painkillers. So during this whole experience with the anxiety, with being on a ventilator, not being able to walk, having to relearn how to walk, she didn't want to take any pain medication because she was terrified of being addicted again. So it was just like one thing after another.
Well, and she can't communicate why either.
Exactly.
It
Exactly.
looks like being stubborn, oh, I want painkillers, that sort of thing. But she has a very strong reason.
Exactly. Communication wise, before she got her speaking valve, I was the true future SLP that I was, brought in like a communication board that I just printed from online and I was trying to get her to point. She was able to write just a little, but it was really hard. When she was in the ventilator weaning place, they trialed a speaking valve on her when I wasn't there. It ended up being a good fit for her. So the next day when I came to visit, she had it on. I didn't realize that it was on. She like sort of gestured for me to come sit next to her. I can send you the video if you wanted to embed it into this podcast. It's a really nice video, but she like gestured for me to come sit next to her and all she said was hello. And I was just in complete shock. I was like, I hadn't heard her voice for like a month and a half. It felt like my mom was back. To be able to hear her voice, to be able for it to just be a surprise. And her speech therapist was an angel on earth because she had really, really horrible suctioning experiences from respiratory therapists who would just kind of come into her room, suction her as hard as they could. She often had blood coming out. It was just a very traumatic experience. And her speech pathologist really, really advocated for her. There were signs in her room that said, be careful while suctioning. There were signs in the room that said, if you have a problem, call the speech therapist at this number. She was an angel on earth. And it really helped me see how important just seeing patients as human are. There were so many times people came into my mom's room and were screaming, hi, Miss Walker, how are you? I'm like, she's not deaf. She can understand you. She just cannot talk back. But all of those experiences helped make me the speech pathologist that I am now.
Sam, that's a remarkable story. There are so many things that I want to pick up and talk more about, but I'm just going to let it sit for a minute. I want to process that a bit more. That's so much to it. Sorry, Jo, were you going to say something? I might have interrupted you.
No, but I'm glad to hear that you had a really supporting speech therapist that just gave those directions. And I just feel, and maybe because I love our field like you do, and I'm glad you do because you're going to be a warrior for the next 30, 40 years. But I really feel like we're the center of that communication hub from all of the healthcare workers. And PT and OT get them up and move them. I get it, but they get to the next patient. But we get down and dirty and patients tell us really personal things. You know, a lot of them dark secrets that they have not shared with people. And it's our job, I think, to be that hub to communicate. So I'm glad that she had signs on the, you know, and the get to know me poster that we use for people, anybody that's intubated, we have a get to know me poster and it's huge. And it says likes and dislikes and all of that. So that is humanizing a patient. So it's not just a body in a bed.
Yeah.
It's hard. It's hard because you have to learn as a speech therapist or speech pathologist, whatever you want to call us, to be that empathetic person, but have that detachment, because you cannot get attached. They are human and you care, but you have to learn those boundaries. They're tough boundaries to learn, but I'm glad that's cool that she just waved you over and didn't say
Oh
hi.
my gosh, I know. I need to send you guys a video. It is so cute. But it's really true. The speech pathologist was the one person that sat and gave her the 5 minutes to just vent, to just see how she is, to hear how her psyche was that day, because it's emotional. She went from a full-time manager at a cardiologist office with 5 doctors to then not being able to feed herself, to communicate when she had to use the bathroom. She had to use the bathroom in her bed. It was just heartbreaking for her, and she wasn't able to communicate those feelings. And the speech pathologist was really one of the first people that sat her down, but then also sat us down as a family and said, if her speaking valve pops off, this is what you do, or this is who you call, or if she starts coughing up secretions, this is what you do, this is what you call, because this is all new. I mean, I had a mom that had a drake in her throat now. I didn't know what sort of that was going on. And then getting it removed was also a bit of a traumatizing experience for her, because they put the wrong size trach in her, because she's a very small woman. They put the wrong size. It was too big. Then we took it out. They had to I wasn't there, so I don't know the actual story. And I was like, oh, it sounded like mom was in pain. So I don't want to actually hear the story. But she had a doctor come in and had to put stitches because they made the hole too big. It was pretty crazy. But for a while, she never wanted to see her throat. She never wanted to give pictures because of the hole, waiting for it to close. It was different. Now she's getting older, there's more wrinkles around here. She's a lot more self-conscious about it. But this experience is going to be something she remembers for her whole life. But also her speech therapist is going to be someone she remembers for her whole life. She has gone back to that hospital and brought bagels and brought lunch and brought dinner. I've went there and talked to the speech pathologist when I was going into graduate school. So this was like a long lasting impact that someone on her journey, had by just slowing down and saying, are you okay? What do you need?
Seems like the competence was so important for the speech pathologist to know what to do. But without the ability to relate to your mom as a person and just spending that time, I can't imagine the impact would have been anywhere near what it is. And I think me included, I likely get, I don't want to say too focused on competency. We want to be very competent and we can explain and provide good education. But to the exclusion of empathy and humanity, of seeing individuals not as a broken car that we're going to fix, but a person who has values and feelings and wants and needs that we can relate to. I mean, that's what makes practitioners exceptional. And it sounds like that's why your mom's going to remember this individual. And I mean, there's so much to take away from this, but that's a tremendous motivating factor also for what we do, not just going through the motions, but when you know the person as a person a little bit better, I think you get more invested. I'm not gonna lie, I have a hard time with that whole detachment idea. I want to be everybody's friend.
Yeah.
Right. But I know it's got to be there. And maybe y'all can help me to figure that out a little better. But it's so motivating when you care and you see the humanity in somebody. And I just can't imagine how rewarding it was for that therapist to see the look on your face when your mom said, hi.
It was an amazing feeling. And to this day, we call the day that she went into the hospital her life anniversary. And to this day, I repost that video every year because it was just such a turning point in her care, where I was just like, okay, she can talk. She can tell us when she's in pain. She can tell us when things hurt. It just made so much of a difference, because My mom, being in chronic pain her whole life with scoliosis, she has such a high tolerance for pain
Yeah.
that when she did say it hurt, it was excruciating at that point. So being able to verbalize those feelings as the pain got worse, now she can talk about her fear with pain medication. It just opened up the door to the turning point of her sort of progress.
Absolutely. That's
I have a question.
remarkable.
Did they ever ask you or your family members to journal?
They didn't. My dad was crazy about writing every single down. He has notes. My dad, I would say he probably can go to med school after this whole experience because he knew everything. I mean, this, ties into the whole speech pathology being there too, because when we had to make a decision on whether or not to keep her intubated or to trach her, it was a hard decision because none of us knew what that meant. None of us knew really the consequences of it. And because my dad had all the information, he was able to sort of reach out to all different hospitals and say, like, look, this is my wife. This is everything that she's done in the past 2 weeks. She's been weaned off this. She's a little lower on the oxygen that the ventilator is giving her. He had all of the information, but I don't know if they told him to do that or if that's just something that he did on his own.
That's just I learned that a long time ago from somebody. So I've asked my family members, and I'm glad your dad did that because the patient needs to see that. I always write down not just what's going on, but your fears, your frustrations, the baby steps forward so that when your mom is getting better and she doesn't think she's better, but you guys are like, oh, wait a second, look at this. And that's what really helps patients too, is they just see, oh my gosh, they don't really realize that the family members are just as much the patient as the patient.
Yeah. Yeah. I will say I took a lot of videos of her. I can share with you. I made like a 1 year anniversary when it was her 1 year life anniversary. I can share with you if you want to embed it here. She loves telling her story.
Yeah.
But I took lots of videos. I can show you this picture I pulled up. I don't know if you can see it.
Oh, look at that.
That's her. But it was a wild ride. It was a wild ride, but it changed the way that I sort of go about being a speech pathologist, I think. I think it was just life-changing in general. It's a crazy experience. I will not wish it upon anyone, but it has changed me.
Sam, can I ask, through that experience, truly seeing things from both sides as a speech pathologist and on the patient side, what are some of the biggest takeaways that you have from that
Um,
as a professional, let's say?
I will say be cautious in how you explain things to patients. I mean, you can see there's a huge difference between someone who just needs to get the information out to the parents and moves on to the next patient and someone who takes the time to explain it in a way that I understood. The ARDS thing was one. Had a doctor come in and say, it's not looking too good. You should have the family come in and say goodbye. We said goodbye to my mom at some point because we didn't know what was going to happen. And just in moments like that, because being on the family side, like I couldn't even think straight. I could barely even get through my classes. I didn't drop out of school. I didn't drop any classes. I just kept going. I didn't stop, but I would say just be careful how you explain things to patients and just always look at them as human. I mean, we're very used to getting stuck in our ways. We wake up, we go to work, we treat the 9 patients we see, and we go home, right? It's number, 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 which is, it just happens to most of us. We just go into this sort of thing. But on the patient side, you can tell when someone, I don't want to say cared, but had the time to just sit down and talk to us. So that really made a difference in her care. Yeah, I think, yeah, it's hard because I'm someone who, whatever they said to me about my mom, I was able to take, internalize, and just figure out what I'm going to do next. My younger brother, he would go white. He would go white. We were scared he was going to pass out all the time because he just couldn't handle this information. So it really just also depends on, and I can't expect the SLP to know the dynamic of the family, but there's just certain ways you can go about explaining things that sound less jargony. It sounds more helpful. Like, I'm going to drop this ARDS thing on you, but I'm also going to tell you not to look it up. And I'm going to give you suggestions on what we're going to do with your mom to help her, right? They made it personal. And I think that's what helped too. They helped walk me through the progress, what's going to happen next for both myself and my mom, because
Sure.
she had anxiety. I mean, the whole ventilator weaning progress for her was so anxiety inducing. As soon as they would lower the amount of oxygen she was getting, her heart rate would shoot up. And they oftentimes just couldn't do that test
Yeah.
because of the anxiety.
The importance of counseling in graduate school, learning how to communicate like that in a way that you deliver the same information, but you deliver it in a way that's considerate of the person who's receiving the information. But even the better you understand something, the more competent you are, the better you're able to explain it in terms that other people can understand. And one more thing with that, you're able to read people, right? So like you responded to it differently than your brother did. You said your brother turned white and kind of shut down. And so being able to calibrate how you're going to tell people based upon how they start responding, that's huge too.
I think I think that takes practice though. I think that takes a lot of practice. And I think that this is a gap that we can fill. Like Joe was saying before, there's so many clinicians out there who are willing to provide the stories of the people that they treat. We can have a complete full day of mock situations where students go in and out of rooms talking to fake parents or whomever just to get the initial nerves out, just to
Yeah.
get what you're going to say out. Because a lot of the times, the first time I experienced sort of talking to a patient's family was when I was talking to a patient's family. I never had that practice before. I will say my graduate school did a really cool experience. We had speech pathology students and physical therapy students. And for a full day, they hired actors and actresses that came to our school who acted as fake patients. And I'll tell this story always because it was one of the biggest mistakes I made, but I laugh about it now because I had the opportunity to make that mistake in front of someone who, like, it wasn't detrimental to them. It was all fake. And now I'll never make that mistake again. I had a patient who was NPO. I was shaking in my boots this entire time. And they recorded it so that we can go back and give ourselves feedback. And the entire time I went in there, I spoke about Indian food. I have no idea why. I just sort of blacked out, but I just talked about food the entire time. But it allowed me that experience to make that mistake in a situation where there wasn't really anything at risk.
That's fantastic. And that's one of the things I loved I worked full time at Rocky Mountain University of Health Professions for 5 years, and I still do adjunct work there. They take their MS Med SLP students to the simulation lab, I don't know how many times, but they let them learn the environment and learn how to make these mistakes. And like with actors, I was usually the patient and made it pretty hard on them, but it all in fun. But they did something to me that wouldn't really hurt me. It might hurt my feelings if they were mean, but I mean, they were able to make mistakes in a safe place.
That's what it is. It's the safe environment to make these without judgment or without fear of, I talk to graduate students nowadays, and most of them are just so terrified of getting kicked out of graduate school. It is such a huge fear that they have.
Yeah.
So much so that they're not taking risks in graduate school. They're not trying for the aphasia patient. They're not going for the extra evaluation because they don't know it well enough where they can assure themselves that they're not going to make mistakes. So they don't do it. And then when they're sort of put out into the real professional world, they don't have any experience with this stuff because they were terrified to do it in graduate school.
That's too bad. I mean, we still learn. I wonder if it would be interesting to see if universities could tap into the outpatient speech therapy world and see if real patients would want to go to your sim labs. So
Yeah.
you see a patient who's got a left or right hemi, when you see a patient who has a dense left hemi taking outpatient speech therapy and physical therapy, breakdown and cry in front of you. What do you do with that? I bet there would be patients who would say, I'm happy to do that and show you. Wonder if they could, that's that whole what we talked about before. I love academics because we need the people in academia to teach us the nuts and bolts on stuff. And then you need the clinicians to make a shorter bridge. But why don't we tap into outpatient stroke patients or outpatient TBIs or outpatient head and neck cancer patients and say, would you be willing to go to Rocky Mountain or wherever, whatever university, San Diego State University, and let speech pathologists see what a head and neck cancer patient look who's been radiated for 10 years. You don't know what that is until you see it, right? You see pictures.
Yeah. Well,
I wonder, that'd be a cool thing to design.
that would be, I mean, especially people who have been living with the condition for so long that they're maybe a bit further removed from the trauma and can learn a lot from their introspection for the past
That's
10
why I
years.
said outpatient, because
Yeah, yeah.
what you learn as an inpatient therapist, what I try and train any
Mhm.
acute care therapist will train an CF or someone who's coming in on board is this is a person who was golfing the other day, man, or an engineer or a
Mhm.
fireman, or whatever where they were doing,
Yeah, living their
housewife,
life.
whatever they were doing. And like your mom, they're a normal person who is a manager of something, and then they're slapped into this situation that is horrifying. Hospitals are our second home. And you just think you can't load them into you can't tell them everything that's going to happen. You know what I mean? But you got to give baby steps and read the room and read those patients' family members. By the time they're an outpatient, they've understood they've had the stroke or the TBI. They know what their goals are. They know they need to get to this point. And
Yeah,
you know what I mean? That's why I'm thinking maybe those patients would be better to tap into. Certainly not an acute care patient, but
that's a great
just
idea.
patients who have already solidified, I know what my goals are. I know what I will be able to gain back and what I may not be able to gain back, and help a student learn that.
We had a sort of event in my counseling class in graduate school where our counseling teacher had about three patients come. One had a stroke, one had aphasia, and I forgot what the third one was, but it was experience to hear the patients talk about the good and the bad things that happened to them while they were in the hospital, giving us sort of that secondhand experience of like, okay, I know not to do that. Or I know that when I go into a patient's room, the first thing I'm not saying is, okay, we're going to do an evaluation. It's hi, how are you? Hi, how are you today? Did you eat anything? Are these your family members? Tell me about them, whatever the case may be.
I'm just bringing you a brief interruption that helps to keep this podcast going. There are hours and hours that go into producing each episode, and I'm very thankful that Bracco Diagnostics is sponsoring this episode of Swallow the Gap. Bracco is the maker of Veribar barium sulfate products, which are FDA approved and the only premixed, pre-measured, and precise barium products for modified barium swallow studies. For more information, please visit veribarbmbs.com. That's VARIBARMBS.com, and let them know we sent you. Sam, I want to circle back to something else that you mentioned. You talked about how students are terrified of getting kicked out of graduate school. So being afraid to make mistakes, but that experience allowed you to make a mistake in a safe place. The idea of being afraid or ashamed of your mistakes is so detrimental to learning, versus seeing your mistakes as an opportunity to become better. This is an area where I need to improve. But also, I believe that it creates a pretentious environment where you pretend to be somebody you're not. And then other people pretend to be somebody, and you think everyone else has their crap together, and no one has their crap together, but they're all afraid to talk about it because they're afraid of being judged. It's not a safe place for learning. And without being vulnerable about our inadequacies and where we need to improve, I mean, we can't do anything. That's the idea with self-reflection, is knowing what are my strengths, what are my weaknesses. And if we don't have any assistance with self-reflection because we're pretending like we've got it all together, we are not going to grow like we need to. So that's a huge soapbox for me. That's just a big,
I
big
think
deal.
that social media has a huge part in that.
How so?
Especially post-COVID, there's been a lot more speech pathologists on Instagram, and everyone's feed is curated. Everyone's posts that they put up are perfect. It feeds into that whole perfectionist standard. They're like, oh, if they can do it, if they're in graduate school and they're able to, run the social media page or have a perfect outfit or whatever the case may be, it feeds that perfectionist standard. And then graduate students, when they do get a bad test grade, they don't want to share it because their friend on Instagram just shared that they got 100,
Yeah.
and that's pretty much why I started Speaking of Samantics. So I was like, everything is so perfect on here. I'm not afraid to say that I have a 3.2 GPA or that I failed my research methods midterm in graduate school, because it happens to all of us.
Sam, you're modeling vulnerability, which, and how many people, you have like a gajillion followers, 75,000 or something like that. I mean, collectively, I don't know, but just that to me, just solely modeling that vulnerability and helping people to be more authentic is invaluable. It is so invaluable. And that's the missing piece from so much of what we do. We look for 4.0s with maybe a B in undergrad, but the soft skills, the idea of you might not get straight A's, but you're going to learn it and you're going to bring your personality to it, and something that can't be learned. What am I trying to say? There's something else here that I'm trying to tap into and my brain's just not getting there.
Can't be
But
tested. All that stuff really can't be tested. Your heart, your giving heart,
yeah.
empathy, that's not tested in graduate school. And that's a huge, huge, huge part of being a speech pathologist.
Well, practical skills, doing things within clinical settings, not just taking them on a test. And we have clinicians who, of course, mentor and supervise, but at the same time, like, they don't receive a lot of training, not in standard. Some places do a great job with it, but I mean, they're required to maybe have 2 hours of continuing education training and be so far past their CF. What I wanted to mention, though, with the 4.0, the super high GRE scores and all of that, it really seems conducive to this type A personality who has not learned how to fail. And not that I don't want to say that no one with a 4.0 has learned to fail. Like, maybe that's why they have a 4.0. Don't mean to be judgmental. I'm making a general statement, is that so many of those people have done well for so long that it might be harder to deal with failure. So maybe we need to look also for people with lower GPAs, but excellent motivation and just great people skills, a willingness to learn, a growth mindset. I remember one individual who we were really on the fence with admitting to grad school. She came in and rocked it. I mean, she was one of the best students I've had to this day because of her enthusiasm, the way her personality shaped the culture of the cohort and made them want to learn. There was just so much to it. And I could talk about this forever, and I'm not going to. I'm sorry if I talk too much, but this is fantastic. Thank you.
I appreciate that. It's the whole collaboration over competition.
Mhm.
That's a huge part of it. I also think that it's hard for people who are in situations like I was. I went into graduate school applications with a 3.2 GPA, and I was proud of that because I got that while helping my mom fight for her life. I got that while
Mhm.
figuring out my life while my mom is now recovering at home. I got that while doing so many other things. It breaks my heart to hear the stories of the students who have the empathy, they have the passion, they have that, but then they don't have the GPA, or then they don't have the GRE, and they've gone through application season after application season, and it's heartbreaking. It's really hard to get yourself back up after denial, especially when most schools don't give you feedback. It's expensive, it's hard, and you're on your emotional state. It's a lot. So I think the graduate school application process sort of teaches us that anything less than a 4.0, or sort of just perfection in general, is risky when you're applying to graduate school. And then we forget to sort of leave that mentality at the door when we get into graduate school. Like, we're here, we made it. Now it's our opportunity to learn as much as we can for the next 2 years. We still have that competition. I'm competing with the people in my cohort, or I'm competing for my seat to be here, or I'm competing for the best externship. We forget to lose that. So, then you have cohort members competing, but not actually saying it. So then people only say the good things about their journey, and it just leads people down, only seeing the highlights of everyone and not sort of the whole story.
There's a parallel between what you're talking about with students and what you're talking about with patients with the soft skills. In both cases, you've stripped the individual of humanity. You've stripped the students of what makes them human. You've stripped the patients of what makes them human, versus allowing us to succeed as humans because, hey, that's what we do best. We've been doing it our whole lives. And so that's such an interesting thing that resonates back and forth between those two principles. Uh, Thank you so much. And Jo, I feel like I've probably interrupted you at least 100 times.
No, not at all.
Is there anything?
I just would love to help any Sam and connect with, so that if she needs stuff, boy, there's so many of us out there that would be happy to help. You know what I mean?
Let's do it. Let's change this.
Happy to. I mean, Tim can give you my contact numbers and all that, and we can exchange things. But to me, it's listening to you. It brings you back to when I was in grad school and stuff, and just that reality. And the other thing, there's a whole nother topic about this, is about life and death, and how to teach a speech pathologist that I guess some people at first call me cruel, but I take the entire caseload of somebody away, and I said, you need to be with that person when they die. And they're just like, I'm scared about that. And I said, you're working in a hospital, you're going to see some dead people, and you need to give them compassion for that. and promise their family members are not going to be alone. And I had to deal with it a lot in COVID on iPads. And I promised people, I will not leave your dad. I will not leave your brother. I will be here until he takes his last breath. And just things like that we don't learn in grad school. I had a 42-year-old who decided she wasn't going to be on her CPAP anymore and she was going to go home and she was going to die. When you just sit there and the family was around and nobody wants to talk about the elephant in the room, but the patient wants to talk about it. She's made that decision. And I just said, this is kind of a great way to go out. You can go out on your terms and say the things you want to say to those loved ones so that they remember them the rest of their lives, and give them the ability to communicate about that. Give them the ability to be okay with life and death, which is really tough for a speech pathologist because we want to fix everything. And sometimes you just can't. And then to embrace that, that's a whole nother topic, Tim, that maybe we can do with Sam. And it just how to teach students that that's going to happen. And I let my colleagues spend the day and I'll just take their caseload away so that they don't have to worry about productivity and they can be in the moment, just stay in the moment with that patient and then go home. And you got to learn to let it go because your partner or whoever you're living with isn't a speech pathologist and doesn't want to hear it. But you know what I mean? Those are those soft skills you try and teach them. And you got to always, my attitude as a speech pathologist is we always have to support each other and lift each other up. We do some tremendously difficult things and support our colleagues. Like if you're having a bad day, give me your caseload, go do what you need to do and support each other, even when we're having bad days and we're not doing well.
And I always tell students, the first part of that is communicating for yourself. We're so good at teaching everyone else how to communicate. Yet when it comes to communicating for ourselves, we bottle it all up.
Yeah.
It's okay. Like my colleagues will come in first time when someone's coding, I said, you need to go watch a code. I don't want to do that. You need to see what a code really looks like, because when a family member says, I don't know, what is this like? You can tell them. I mean, it's not what you see on TV. And I'll just say, you should watch a code, man, and watch them get cardioverted, watch a body fall up, fly off the bed and get cardioverted. And it's something that you need to see so that you have a better understanding, that compassion with a family member, that you can explain it to them how they can understand it, versus that medical team saying, well, we're going to slap these things on you and we're going to get you back in rhythm. And I'm like, okay.
It takes speech pathology out of being just like textbook definitions of things.
Well, it's an experiential thing, which is kind of what you're talking about, Jo. It becomes, you see it, you hear it, you smell it, and you don't just read about it. So I think that's cool. I'm going to say something at the risk of really sounding cliche and cheesy, but I believe in it a lot. Both of you, in very different ways, have affected such tremendous change. Jo, how many ICU programs, dysphagia programs have you built, helping with passing mirror valve? Your influence has been tremendous. And even just with me, so Jo lives in southern Utah. I live up a little bit further. Like you've just modeled what it's like to be a good person as a clinician and be so giving in your time. I mean, the second podcast I've had you on, you're doing some other events. I appreciate that so much. And Sam, what you're doing and modeling vulnerability and helping students to not be afraid to learn and helping them to learn in a way that makes sense to them versus just a textbook, that's tremendous. And so by the evidence of what's already happened, by the evidence of the change that both of you have affected in the lives of so many, and looking at the current state of how things are, that gives me a lot of hope and a lot of faith in our ability to continue to change things and make things better. We don't have to be satisfied with how things are. We don't have to be satisfied with the status quo. We can make things better. We have that power. We've got to believe we have that power. We've got to synergize and we've got to have vision and do this. So let's do it. I mean, this is so cool. Your story, I've had tingles probably more this podcast than I haven't. And yeah, it's an emotional topic. Very emotional. Thank you both so much for coming on. Anything else that you want to leave listeners with?
Thank you for saying all that. That was so nice. I will just say to anyone who's listening out there, just be yourself. I feel like we think speech pathology is one mold that we have to fit in, and everyone has to fit into the same mold and be the same. But
Nope.
let's start honing into our individuality. It makes us special. It's what made my mom's speech pathologist special. You know, I still remember her name. I could probably find her on the internet somewhere and reconnect, but she was special to me. Everything about her was special to me. So just be yourself. It's what helps, again, bring humanity back into speech pathology.
As much as I admire Jo, I don't want to be exactly like Jo. I want to know half as much as right? But I want to be myself and as smart as you. Right?
Oh, sweet.
Just be. I get what you're saying. There's so much in the diversity that we bring to the table.
I think it's a cool profession, and I get excited to see people like you, Sam, because it's like our profession is going to continue with really, really good people. It's nice to see. I love it. I love seeing it. Inspires me to continue to see you guys do what you do.
Yeah, and a lot of it is for our future SLPs. Our future SLPs are going to be the next people who are running this profession, and I think that for all licensed SLPs, it's good to think about yourself in graduate school because it allows you to remind yourself of how hard it was and how incredibly hard it is still for graduate students.
Yeah, the empathy piece for sure.
Yeah.
Well, thank you both so much. I think I kept you longer than you had time for, but it was worth it. It was worth it. All right.
Thank you so much, Tim. Appreciate you.
Thank you.
Yeah, absolutely. Again, Jo Puntil, Sam Walker, thank you for joining us, and we'll see you next week. This was encouraging to me and a testament to the impact that we can have as speech pathologists. To me, the discussion emphasized also the importance of bringing our own individuality to our clinical roles. There's value in our uniqueness and the diversity that brings. I love the perspective that Sam communicated stemming from her experience with her mom, her own graduate school endeavors, and through her communication with students. Let's model and facilitate an environment where learning is enjoyable and stimulating. Also, don't underestimate the power of your influence for a noble cause. There are so many of us who are done with the status quo and willing to fight for a better level of care and a stronger level of compassion that helps to harmonize humanity and professionalism. Thank you so much for listening. If you haven't already signed up for the webinar event, Dysphagia in Patients with Pulmonary Compromise, ICU and Beyond, the early bird rates will be gone in less than a week. The standard rate will start on April 1st. I really believe the expertise and conversation in this event will support our ability to be exceptional clinicians in complex medical settings. In fact, if you haven't signed up yet, send me an email with the subject line webinar, and I'll provide the first person who does this with a CFY rate of $65. For webinar details, please visit swallowthegap.com/live courses. Thank you so much for listening. We appreciate you, and see you next week.